Good morning, good afternoon, good evening to each and every one of you. Today, we are here for HCP Virtual Classroom, session number 2. We want to heartily welcome Dr. Leena and Dr. Rachana from Tilganga Institute of Ophthalmology. They are here to teach you chapters 7 through 12.
I'm Dr. Leena Bajracharya. I'm a consultant cornea specialist at Tilganga Institute of Ophthalmology. So I'm going to talk about chapters 7 through 9 about degenerations, corneal dystrophies, and ectatic corneal diseases. Degeneration by definition is a physiological decomposition of tissue elements and function due to aging or environmental insult. Okay, and dystrophy are inherited conditions arise from genetic mutation without relationship to environment or systemic diseases. Onset is early in life and progress slowly. In corneal degenerations, opacity involves periphery, but in corneal dystrophy, opacity is often centrally located with limbal sparing. Degenerations are typically bilateral but asymmetric. Dystrophy typically bilateral and symmetric. So I'm going to talk about those which are common mostly, and those which are not common I have not included because of the limitation of the time. Okay, so pterygium and pingocula, and as everybody know, is the most common cause of conjunctival degeneration. We can see the fibrovascular tissue encroaching in the cornea and this pale yellowish nodule as pingocula. And pingocula and pterygium, they share common histological features as well as predisposing factor like ultraviolet exposure and dust, and they are more common in hot climate equatorial region. And you can see in this pterygium Stocker's line, which is the iron pigment deposition due to irregularity of tear film. And most important difference is that pingocula doesn't encroach the cornea, whereas pterygium can encroach the cornea. And pterygium, and this is the topography map of pterygium before and after surgery, and we can see that pterygium can induce astigmatism. We can see this astigmatism and irregularity of the placido disc, and after surgery, pterygium surgery, it is round and regular. So if you want to do cataract surgery first, it is better to do pterygium first, because we have to plan a corneal incision as well as we have to accurately calculate the IOL power. So in case of pterygium, when there is suspicion like calcification, leukoplakia, feeder vessels, abnormal vessels, or if there is a keratin plaque, then we have to send for histopathological examination to rule out neoplastic disease. Otherwise, in normal pterygium and pingocula looking, we don't send for histopathology. Okay, this is important because sometimes we may be confused with pterygium. So this is the high resolution anterior segment OCT. OCT of the upper one is the pterygium, which shows that this is the dark layer is the epithelium, which is normal. In the pterygium, beneath the epithelium, there is fibrovascular tissue, but in this lower picture, the epithelium, the darker epithelium zone is suddenly become bulky and hypertrophic, which signifies neoplastic growth. So this is the anterior segment OCT is a useful tool, non-invasive, useful tool to distinguish suspicious lesion. So conjunctival degenerations also include conjunctival concretions, conjunctival epithelial inclusion cyst, which are also quite commonly seen. Usually treatment is required if symptomatic, and multiple punctures can be done, or even excision if recurrent. So another is conjunctival callosis, which is poor adherence of bulbar conjunctiva, and there may be conjunctival vascular tortuosity and hyperemia in the ocular surface. These are the causes of conjunctival vascular conditions, which I want all of you to go through. Now coming to corneal depositions, this is a picture of spheroidal degeneration. It may be primary or secondary. Primary without any cause, and secondary usually after trauma or after infection, after past infection. And in this mesenteric stain, we can see the protein deposition. Band keratopathy, it is also a common entity in our clinic. It can be idiopathic or secondary to ocular disease or systemic association. And when it starts from the temporal and nasal side and as it progresses, it may affect vision, and we can do treatment by EDTA, ethylene diamine tetraacetic acid chelation, or PTK, or superficial keratectomy. Recurrence is common, so follow-up is important. Yes, follow-up is important. It can cause pain after erosion of the epithelium. So this table shows the causes of band keratopathy, systemic as well as ocular conditions, again, which I want you to go through. And Salzmann nodular degeneration is also again a common condition in which we can see the gray-white nodular lesion in the surface, which is the hyaline deposition. It can be primary or secondary. In secondary, it may be because of long-standing keratitis like pectinulosis, trachoma, and treatment is superficial keratectomy or PTK. Again, recurrence may be common. So this is the picture of corneal arcus. It may be senile and juvenile. If it is juvenile, again, we have to think of hyperlipidemia. If it occurs in younger patient and have to do lipid profile. And in senile arcus, if there may be thinning of the lucid zone, and which we call porodegeneration. This becomes important in case of cataract surgery, because there will be thinning here in the lucid zone, and we have to specifically avoid the thinning area. Otherwise, there may be problem in the self-sealing of our cataract wound. So again, now this is a picture of crocodile saccharine, which is a mosaic pattern, and the opacities are in the level of Bowman's layer. Usually treatment is not required, and prognosis is good after cataract surgery. I mean, there is no postoperative significant postoperative edema. So visually it is not significant, but it is quite commonly seen here in our clinic also. So this picture is polymorphic amyloid degeneration. We can see refractile bodies and lines, which is the deposition of the amyloid, and usually visually not significant and no treatment required. It may be confused with the lattice corneal dystrophy. Terrier's marginal degeneration is also a type of dystrophy, which is cause is unknown. It can induce astigmatism, and it is characterized by thinning in the periphery. Starts in the periphery, it gradually progresses circumferentially, and when we look closely, there will be fine blood vessels along with the lipid deposition. Deposition, and sometimes this may be confused with peripheral ulcerative keratitis. And distinguishing feature is that in Terrier's marginal degeneration, there is no pain, no redness, no photophobia, no epithelial defect, whereas it is present in PUK along, and maybe in PUK there may be systemic association like rheumatoid arthritis, SLE, and so on. And treatment is not required, but we have to treat induced astigmatism, and if it is severe, there may be chances of perforation with minor trauma, and then so we can do tectonic crescent-shaped laminar graft in case of severe Terrier's marginal degeneration. Another condition is corneal keloid, which is rare, which is not common. It is hypertrophic corneal scar following trauma or infection. Lipid keratopathy is a deposition of lipid which comes from the corneal vascularization, and treatment depends upon the site of the lesion. And if we treat corneal vascularization with topical steroids or laser or anti-VEGF, sometimes this may regress along with the regress of the vessels. When vessels regress, the lipid may decrease or it may be cleared after regression of the vessels. So there may be different deposits in the cornea, and I think and you all know about Fairy line, Fleischer ring, Hudson-Stanley line, Stocker's line, and other deposits may be like in gold. In case of gold, sometimes rheumatoid arthritis, during treatment of rheumatoid arthritis, gold salts may be used and it may be deposited in the stroma. It is not common. And cirrhosis because of iron foreign body and blood staining may occur in case of hyphema. So these are some important deposits which we have to know. So other deposits are KF ring, which Dr. Rachana will be talking about, and others are some important Krukenberg spindle in case of pigmentary glaucoma. So IC syndrome is another type of dystrophy in which there is abnormal proliferation of endothelial cells which migrate towards the antechamber angle and along the surface of the iris, and we can see the nodules and correctopia and multiple iris, multiple pupil because of the contraction of these cells. This is a picture of picture of vortex keratopathy, cornea varicillata, which is the deposition of the different types of drugs, medications like amiodarone, chloroquine, hydroxychloroquine, indomethacin. They bind with the lipids of the basal epithelium and they deposit in the manner of this type of lines. Usually, visually it is not significant, but if there is decrease in vision, we have to think of posterior segment toxicity, like just like in chloroquine can cause retinal toxicity, tamoxifen can cause optic neuropathy. So if there is associated vision loss, we have to think of these conditions and evaluate properly. And chloroquine ciprofloxacin deposition is also a common because we use ciprofloxacin quite common here, and usually it deposits on the epithelial defect in an infiltrate or trauma. Senile scleral plague. This is the plague which is degenerative change in the sclera and calcification. Sometimes calcification can also occur. So now coming to corneal dystrophy, that dystrophies can be classified into 4 types: epithelial and subepithelial, epithelial and stromal dystrophies, and endothelial dystrophies. So this shows the various types of dystrophies in each category. I'm going to discuss the important ones. So gene locus and gene responsible for dystrophies are shown in this table. And again, you may have to remember the gene locus and gene of important corneal dystrophies, important and common dystrophies. So coming to the epithelial basement membrane dystrophy, which is commonly seen, and about 6 to 18% of population in US have this type of dystrophy. It is the abnormality of epithelial turnover and production of basement membrane. Clinical lesions may be like map-like, dot-like, or finger-like projection. And so this condition is bilateral, but if it is unilateral, we have to ask the history of trauma, because trauma can also predispose to recurrent corneal erosion. And we always have to examine the fellow eye, because in the fellow eye we can find these lesions. So this picture is again showing the loose epithelium and negative staining, and keratometry. Keratometry shows irregular Myers, which is because of the irregular epithelium, and this can cause decrease in vision and discomfort. Sometimes the map dot lesions may mimic intraepithelial dysplasia of the cornea, like in this picture. This is the corneal lesion, which is mimicking mapped out changes of the epithelial basement membrane dystrophy. In suspicious cases, we have to send for the histopathological examination. So management is antibiotics, lubrication, epithelial debridement, hypotonic sodium chloride, and for recurrences, we can do anterostromal puncture, phototherapeutic keratectomy. This is misman dystrophy, which is not very common, autosomal dominant. We can see the epithelial vesicles containing degenerated epithelial cells. Vision is not much affected, no treatment required. So gelatinous drop-like corneal dystrophy is autosomal recessive, and clinically there are three patterns like vesicles and like diffuse scarring and again advanced type of dystrophy. So these all come under various types of gelatinous drop-like dystrophy. And the deposition is amyloid deposit. Treatment is deep antilaminar keratoplasty or pattern keratoplasty. Reese-Buckler dystrophy is also not very common in our clinics. It is autosomal dominant. Bowman's layer is replaced with connective tissue along with granular deposits. It can cause marked vision loss and also painful recurrent corneal erosion. Thiel-Benkley corneal dystrophy. Here also subepithelial dystrophies, recurrent corneal erosion can occur, and in anterior segment OCT we can see sawtooth-like appearance. Lattice dystrophy, it is more common than other type of dystrophy. We can see lattice lines which are refractile, and on progression it can cause recurrent corneal erosion and decreased vision. The deposits are amyloid, which stain orange red with Congo red dye. So there are variants of this lattice dystrophy, type 2, type 3, and 4, all share similar clinical features, and you can read yourself. And this table shows differentiation of granular, lattice, Snyder, and macular dystrophy by histopathology and histochemical staining. Granular dystrophy type 1, this is a picture which shows granular dystrophies. Intervening stroma is clear, and usually it is confined centrally, doesn't extend up to the periphery. So vision may be affected in the middle age. Treatment is deep antilaminar keratoplasty. Prognosis is good after deep laminar keratoplasty. And in this picture shows histochemical staining, which stains the hyaline deposit stain bright red with Mason trachom. Granular dystrophy type 2. Here the granules, between the granules there are spike-like deposits, and histochemically both hyaline and amyloid deposits are present. Macular dystrophy is the autosomal recessive, which is the only autosomal recessive disorder. Another autosomal recessive disorder is gelatinous drop-like dystrophy. And you can see in this picture the stromal opacities. Here the intervening stroma is also hazy. The lesions can extend up to the limbus and more deeply than granular or lattice dystrophy, and it can even affect the desmus membrane. And prognosis is not as good as in lattice dystrophy and granular dystrophy, because it can recur more early than the other two types of dystrophy. The onset is at much younger age than lattice or granular dystrophy. The deposits are mucopolysaccharides which stain with alcine blue and colloidal iron. Snyder corneal dystrophy is a rare dystrophy in which the depositions are lipids, and we have to send for the lipid profile of the patients having this type of dystrophy. Congenital stromal corneal dystrophy is autosomal dominant, diffuse corneal clouding. It can cause moderate to severe vision loss. There is abnormality of the corneal lamella, but keratocyte and endothelium are normal. So DALK has good prognosis. Coming to endothelial dystrophy, Fuchs corneal dystrophy is quite important and common. It is autosomal dominant, presence in middle age, female preponderance. So it is characterized by guttata initially, and later on by stromal edema, which decrease in vision mostly in the morning, followed by painful bullae, and then subepithelial fibrosis, scarring, and vascularization as it becomes chronic. And investigations we send is specular microscopy and corneal thickness. So we can see the picture of the Fuchs dystrophy with showing beaten metal appearance of the guttata, stromal edema. So treatment is hypertonic sodium chloride. EK is a gold standard treatment. DMEC is a gold standard treatment for Fuchs dystrophy. And for pain, anterostromal puncture, bandage of contact lens, amniotic membrane if keratoplasty cannot be done. And in cataract surgery, we can combine cataract surgery and EK if there is clinically evident corneal edema. Otherwise, we can do cataract surgery first, followed by EK later on. So posterior polymorphous corneal dystrophy is autosomal dominant, is another type of endothelial dystrophy, which is autosomal dominant, not very common. You can see geographic lesions and vesicles. It may mimic hydrocorneal adhesion and may have rise in IOP. Passes may be asymptomatic. If symptomatic, treatment is similar to Fuchs. And lastly, congenital heredity endothelial dystrophy. It is autosomal recessive. The diffuse corneal clouding and edema, corneal thickness is 2 to 3 times than normal, and because of this, and we can distinguish this from stromal dystrophy, congenital stromal dystrophy, because of the thickness, which is much more in case of endothelial dystrophy than in stromal dystrophy. There is association of amblyopia, nystagmus, and prognosis of PK and EK is poor because of the dense amblyopia. So now we are coming to ectatic disorders, and this picture shows the three types of ectatic disorders: keratoconus, pellucid marginal degeneration, and keratoglobus. The keratoconus is the most common of three, occurs in puberty. It's more common in South Asian population. Positive family history in 6 to 8%. There is an inferior central or inferior paracentral thinning and cone-shaped protrusion. And there are various signs associated with keratoconus like Munson sign, K of ring, which is the iron pigment line. Iron pigment line at the base of the cone. This is Vox stria, which is because of stretching of the stroma. Rigidity sign, which is the triangular shaped corneal reflection when the torch is shined from the opposite side of the cornea. So again, this shows the thinning and protrusion, and we can see the superficial scarring, which is the break in the Bowman's layer. Acute hydrops. In case of, and this is the picture of acute hydrops in case of which occur in the advanced keratoconus due to break in the descemet membrane and swelling of the cornea. So conditions associated with keratoconus, mostly the common one is VKC, others may be retinitis pigmentosa, atopic disease, Down syndrome. So diagnosis is from the topography and tomography, and also in keratoconus we have to monitor the progression, and if progression occurs, we have to halt the progression by collagen cross-linking procedure. So we can see in this picture, this is the Simpson based corneal map showing the increased steepness in the inferior part of the cornea, elevation in the front. This is the picture showing front elevation, back elevation, and corneal thinning. So this is the characteristic picture in the corneal topography. So increased thinning, front elevation, back elevation, and increased steepness and increased thinning. And also this picture shows the displacement of the radial axis. The axis of the cornea is shifted. This is an early sign of keratoconus. We are not seeing any thinning of the cornea yet, and this displacement of the cone, displacement of the center is an early sign. So treatment is glasses, contact lens in the initial, but contact lens doesn't halt the progression. So for halting the progression, collagen cross-linking is the gold standard treatment, and it is done for corneal thickness above 400 micrometer, above 400 micron. And after cross-linking, again we have to go for the visual rehabilitation with contact lenses. Contact lenses may be rigid gas formula contact lens or mini scale contact lens, rose scale lens, and we can also implant corneal intakes for visual rehabilitation coupled with cross-linking. And for advanced keratoconus not suitable for cross-linking, or even after progression after cross-linking, we can undergo DALC, which has good prognosis in case of keratoconus. So this is a picture of collagen cross-linking being performed, and I think all residents know quite well the procedure because they have been doing quite frequently in our clinics, in our OT. So picture of intakes. Now the pellucid margin degeneration, it is also an eutectic disorder like keratoconus. It is less common and occurs in older age group than keratoconus. Thinning is in the inferior 1 to 2 millimeter above the limbus and 3 or 4 clock hours. So steep axis is just above the thinning. So in topography map, we can see the crab claw pattern. So we can see the crab claw pattern, which is characteristics of pellucid margin degeneration. Sometimes the topography may mimic both keratoconus as well as pellucid margin degeneration. It may be difficult to distinguish. So keratoglobus has the worst prognosis than the three. It occurs even younger age than keratoconus. The cornea is maybe very thin, paper-like thin, and ruptured by even trivial trauma is very common. And sometimes it may present because of trauma. It may not be diagnosed until patient comes with trauma. So trauma may be very large with even the extrusion of intraocular contents. So it is if we diagnose and if it is seen to be progressive, we can do tuck-in keratoplasty over the sclera. This is a picture showing the map of the keratoglobus with diffuse thinning and steep axis, diffuse steepness of the cornea. And I think I have come to the end of my presentation. Thank you all for your attention.
Many, many thanks, Dr. Leena. Before Dr. Rachana goes, I want to call upon Dr. Audrey Rustov for just a few minutes on any pearls based on what Dr. Leena has just taught us. We are so honored to have her with us. She was the Global Medical Director of SightLife iBank worldwide. She is an amazing cornea specialist based out of Seattle, Washington, and she is a very, very busy human being. In addition to that, in the United States, it is Thanksgiving, the eve of Thanksgiving, when you are with the family. And you know what she said? And she's in the middle of clinic and patients and all of that. But you know what she said? She said, I will be here for all of you. That's how much she cares. And that's how much all the faculty here care for all of you. So Dr. Audrey Rustov, thank you for being with us today. I hand it over to you to give us your pearls.
Great. Thank you so much, Rachana. It's so nice to see so many of you, Dr. Rita, Dr. Leena, Dr. Rachana. It's just lovely to see familiar faces and also to meet all of the residents.
Hi, Audrey.
Hi, so great to see you.
Yeah.
Hello, Dr. Audrey. It's nice to see you.
Hello. Yeah,
After
so
such a
nice to
long
see you.
time.
I know,
Yes,
I'm
it
missing
is,
all of
it
you.
is. Yes.
And thank you for such an amazing presentation. So much work and so much good learning here. A few things I would say there as I'm trying to frantically answer some of the excellent questions that are coming in fast and furious here on the chat. So thank you all for paying attention and for giving your questions. There seems to be one big thing is what is the difference between topography and tomography? And so topography measures just the anterior surface, the front surface of the cornea. And so you'll have a topographer. This really gives you only about 60% of the data, meaning you're only really measuring about 60% of the anterior surface. Tomography, and this would be like your Pentacam, for example, or Galilei, or I'm not sure what other systems, but like a Pentacam measures both the front surface, the anterior surface, as well as the posterior surface of the cornea, and also provides pachymetry. So you get all of these data all with one machine. Not everybody has access, of course, but if you do, this is a really lovely way to be able to image the cornea, especially for things like keratoconus or CHED, or Fuchs dystrophy, because you're getting all of the data points there. When it comes to someone that had asked about, Fuchs dystrophy, and there was a lovely explanation. So thank you so much about how to decide, do you do Fuchs first or cataract first, or what do you do? I would say in general, like, for example, obviously with CHED, you just need to do a DSEC, do endothelial keratoplasty for CHED. It's a baby or a child, so you just have to do the endothelial keratoplasty. If it's a younger person and they don't have much of a cataract, for example, maybe this person is in their 40s or even 30s, but 40s or 50s, especially 40s, you can then just do the endothelial keratoplasty and you can wait on the cataract. So you can do that first and then wait. I personally like to do DMEC. You can do DMEC or DSEC is fine, and then wait clinically before you do cataract. Same thing with, keratoconus. Keratoconus, usually we're talking about a younger patient. You can do your DALK or your PK. A question came up, how do you decide between DALK and PK? And I'd say sometimes it is decided for you at the time of the surgery, meaning that you start to do your DALK, and then you see if you have a rupture of Descemet's, or it's really, really thin and they've had previous high drops and you just can't do your DALK, then you do your PK. But I say you try to do the DALK. It's not like you say, oh, yes, I will absolutely do a DALK. You hope you do a DALK. And most of the time you're okay, and sometimes not so much. But to be prepared, I would say, for that. And so I'd say those are some of the, the main pearls. The other thing in terms of stromal dystrophies, of which you will see a lot, stromal dystrophies, macular is going to present at a younger age. You just want to watch these children, and then at the appropriate time, you can do a usually DALK or PK. The thing is, these dystrophies can come back, like granular dystrophy. I also try to put off for a while, follow the patients. Sometimes through the granular dystrophy, because there's all these little spots, they actually have better vision than you think they might, because they're looking like almost like pinhole effect. I have also done actually a lamellar keratectomy. I measure with an OCT the depth that it goes down, and you can also debulk the cornea if there's enough cornea thickness. I debulk the cornea by just removing, say, a couple hundred microns, and then sometimes that's enough to improve their vision without also having to do the keratoplasty. This is not in the BCSC. This is just what I do.
Dr. Rachana, who was a previous HCP cornea fellow, okay?
Yeah.
And she is a cornea expert at Tilganga Institute of Ophthalmology.
Yeah.
So today we are represented by the Nepal team of cornea specialists. And Dr. Rita, Dr. Leena, Dr. Rachana are all here with us today, and perhaps others too. So Dr. Rachana, over to you to teach us on chapters 10, 11, and 12.
So, hello everyone. Again, I'm Dr. Rachana Singh. I'm working as a cornea faculty in Tilganga Institute of Ophthalmology. So the chapters covered. Okay, so the chapters to be covered, I have given the chapters 10, 11, and 12. So because I think we have a time constraint, so I'll be dealing with chapter 11 and 12, which I think is very important topic. So I'll be dealing with 11 and 12 chapters, and then later on I'll go to chapter 10. So I'll be dealing with chapter 11, which is infectious disease of cornea, viral infection. So you can see that this is a viral structure. Here, the virus is quite small, 10 to 400 nanometer, very small structure, which has a single or double-stranded DNA RNA genes in the center, which is covered with a protein cell, which is known as a protein capsid. And this is also covered with an envelope. It is present in enveloped virus, and it is absent in non-enveloped virus, which is of lipid contents. And it has got a spike, sharp spikes, which is of proteins. So there's one classification, which is quite common, Baltimore classification of virus. Here again, it is divided into double-stranded and single-stranded DNA virus. It is again enveloped and non-enveloped. So in enveloped virus, we have got very important herpes virus, and non-enveloped, we have got adenovirus. But in RNA viruses, this is again enveloped and non-enveloped. The coronavirus, it is also known as COVID-19, which is quite pandemic in 2019. Still, it's going on. So we'll discuss about all these things. So first of all, herpes virus, which is very common in our continent. I think this is also common in the other parts of the world. So herpes simplex virus is it has many ocular findings. In primary ocular infection, as we see in the first picture, we can see it's a very, very vascular rash over the skin, and also in the lid margins. We can also see that there's a lid ulcers, and we can also see that in the cornea there's dendritic lesions, which is of arborizing pattern. So herpes simplex virus can be divided into 1 and 2. One infection of the wrist, which is orofacial and ocular infection. In herpes virus simplex 2, it is usually infect in genital infections. So herpes simplex virus establishes latent in infection in demonstration of herpes center or PCR is actually a self-limiting condition. Oral antiviral therapy speeds the resolution of the virus pathology. So recurrent ocular virus infection, it almost affects any ocular tissue. So recurrent infection is very typically unilateral. It's caused by reactivation of virus from latently infected sensory ganglion. So we have so many hypotheses that stress of so many things with, again, some in female, it's the menstrual cycle. These all triggers some exam tension, and this is all trigger virus infection. But we have seen in so many times in our OPD, patients say like after the stress environment, I will have these cycles in my eyes. But in his study, this hypothesis has not been confirmed. And it has been seen that the recurrent herpes simplex virus are more in HIV patients. So recurrent herpes simplex virus infections, it also affects in blepharoconjunctivitis also. And in epithelium, as we see that epithelial keratitis is more common. Here we can see that the fluorescent staining of the dendriting pattern. And here we can see again the rose Bengal stain of the typical dendrite pattern. But we know that in our part of the world, we mainly use the fluorescent staining. We don't have a rose Bengal stain, but I think the patient is more discomfort with a rose Bengal stain. So fluorescent staining is more suitable for the patients also. So this is the antiviral agents which are used in herpes simplex virus. Among the long list, I would like to focus on the acyclovir, which is present in our context. I think this is also present in most of the countries. So acyclovir, we have 3% ophthalmic ointment and 5% in the skin. So in the tablet forms, we have 200, 400 and 800 mg tablet forms. I think in the United States, trifluridine, they don't have acyclovir ointment, so they use trifluridine ointment. So herpes virus, they also affects the stroma. Among the common things in the stroma, we can see a unifocal or multifocal stromal haze with no epithelial defect. And here we can see that non-necrotizing stromal keratitis. Here we can see that it's a disciform keratitis. So this is a disc shape with a lot of stromal edema. And so this is a necrotizing viral keratitis. Here we can see that there's a stromal inflammation of the cornea. So herpes stromal keratitis is a result from the immunologic activity generated by the host against virus. It can be non-necrotizing or necrotizing. So interstitial keratitis presents as unifocal or multifocal haze with no defect. Herpetic disciform is there's a stromal haze, epithelial edema with capes underlying. And in non-necrotizing, as I've said, it's a suppurative corneal inflammation, and corneal stromal vascularization is also common. So there's a herpetic eye disease study. So the conclusion of the herpetic eye disease study, it has focused on the long-term acyclovir prophylaxis recommended for the patients with recurrent herpes simplex virus keratitis. Topical corticosteroids significantly decrease the stromal inflammation, and it shortens the time duration of the keratitis. The treatment of non-necrotizing stromal keratitis with oral acyclovir were not been beneficial, and many clinicians favor in use of the oral acyclovir for the treatment of herpes simplex iridocyclitis, but because of the small sample size, it has not been proven in HEAD study. And also oral acyclovir does not prevent the development of stromal keratitis or stromal uveitis after the epithelial keratitis. So the complication of herpes simplex virus, epitheliopathy, neurotrophic keratopathy, metaherpetic ulcers, persistent bullous keratopathy, and corneal scarring. I think the residents should focus on the details of the complications, because most of the patients, there are so many recurrent patients, so they are landed in these complications, and it's very difficult to counsel those type of patients. So when the patient came to our clinic, we have to more focus on the counseling part also, because this is recurrence. Patients just move from one doctor to another. So we have to counsel about the pathogenesis of the disease. So another very important is herpes zoster ophthalmicus. As we know that this is always a unilateral, painful vesicle lesions over the skin and the eye area. This is usually unilateral. And we can see that there's a nummular, in the stromal keratitis, there's a nummular keratitis, which is involved. And also in the later phase, corneal vascularization is present, and there is lipid keratopathy. Actually, this is a sequelae of the herpes zoster ophthalmicus. So regarding the treatment of herpes zoster, oral Bajracharya 1 gram 3 times per day, and acyclovir 800 mg 5 times a day, or famiciclovir 500 mg 3 times a day can be can be started. So it is the effect of these drugs is best within the 72 hours of the onset of the skin lesions. In our context, we don't have other medications, so yeah, we always started acyclovir 800 mg 5 times per day. So sometimes we have to also start intravenous acyclovir therapy for the patients with disseminated zoster in immunocompromised patients. Topical corticosteroids and cycloplegics are indicated for the keratouveitis, and post-herpetic neuralgia is a common complication of herpes zoster. So in those cases, low dose of amitriptyline, desipramine, carbamazepine can be started, gabapentin and pregabalin to manage the post-herpetic neuralgia. In the patient of herpes zoster, what we do is, in our context, we also send the patient to the dermatologic consultation, so that the patient can have the details of the disease also for the skin also. So Epstein-Barr virus, it causes dacroadenitis, conjunctivitis, and keratitis. This is also a herpes virus. So it gives history of recent infectious mononucleosis or persistently high Epstein-Barr virus serologic titers. So it has 3 forms. So we can see that it has multifocal subepithelial infiltrates, pleomorphic infiltrates, ring infiltrates, or deep stromal infiltrates. Here in this picture, we can see that the ring pleomorphic infiltrates is present in the stroma of the Epstein-Barr virus patients. Cytomegalovirus. This is again a herpes virus that infects more than 90% of the humans by 80 years of age, most commonly with sectoral necrotizing retinitis in AIDS and other immunocompromised conditions. So anterioritis and corneal endothelitis are present. PCR testing in aqueous humor can be done. So it can be treated with ganciclovir or its products. In CME retinitis, in CMB, acyclovir doesn't work. So in this picture, we can see that a chain of a bunch of KPs present in endothelium. So again, a very important topic, adenovirus. So adenovirus, here we can see that in adenovirus, adenovirus can present with conjunctivitis, again keratitis. So adenovirus congestion is a very much marked congestion with a membrane in it. So adenoviral conjunctivitis, the patient present with very difficulty in opening the eyes, watering. So we have to look for the membranes whenever the patient came into our OPD, and the membrane should be taken out. So later on, this can lead to the semipermanent formation if we do not take the pseudomembrane. So this is a very nummular keratitis in the cornea, and this can be very much clearly seen in broad oblique slit beam. So I request residents to look at in the broad oblique slit beam so that we can see the location of the infiltrates in the slit beam picture. It's a very beautiful, beautiful picture in the slit beam picture. So this is actually natural progression of the AKC. So in the stage 1, there's a very few staining can be seen. In the stage 1, there's fine epithelial, so AKC can be seen. Punctate epithelial keratitis can be seen. In the stage 2, there's fine and coarse. Punctate epithelial keratitis can be seen. In stage 3, the fine punctate epithelial can be very less, but there's coarse along with the subepithelial infiltrates. In 4th, there are coels and there's more subepithelial infiltrates rather than the punctate epithelial keratitis. So stage 4 and stage 5 consist of subepithelial infiltrates where we need corticosteroid. So among the pox viruses, one of the common is molluscum contagiosum. So there is a very small, tiny, with a very central umbilicated area. So it can be, the pox virus can be present with molluscum contagiosum. Then there is a discharge also. And sometimes in immunocompromised AIDS patient, there's a series of molluscum in the lead area. So this is again papillomaviruses, which is caused by human papillomavirus. We can see that human papillomaviruses are causing this type of thing. So the next chapter is RNA virus. On the RNA viruses, there lies coronavirus, orthomyxoid viruses, paramyxoid. But I just want to focus on the coronavirus, which is a COVID-19 virus, where we can see that there's a lot of follicular conjunctivitis present in our OPDs in the COVID era, and nowadays also in the we can see a lot of COVID patients presenting with conjunctivitis. So now I'll go into the chapter 12, which is again very important: infectious disease of cornea, bacterial, fungal, and parasitic infections. So this is the normal flora of the external eye, where you can see that Staphylococcus epidermidis, Staphylococcus aureus, Corynebacterium, Propionibacterium is present in the normal conjunctiva and normal. So Staph aureus, Staph epidermidis, Corynebacterium are present. So these are the list of the organisms that can invade the intact epithelium: Corynebacterium, diphtheria, Haemophilus influenza, Listeria monocytogenes, Neisseria gonorrhoeae, Neisseria meningitidis, Shigella species. So Fusarium is also added upon this list. So I think this name of the organism should be known by the residents, because this is very important question in the MCQs. So there are different stains and culture media for the infectious keratitis. I know that these all type of stains and this all media is not present in all our context and in other parts of the world also. But what we have to know is in Acanthamoeba organism, for the Acanthamoeba, we have to have the non-nutrient agar with E. coli overlay. So for this is not actually ready in the lab. For the suspected cases in the Acanthamoeba, we have to request our lab technician to prepare for this type of media, and then we can do it. For the aerobic bacteria, gram stain is adequate. For the anaerobic also, the gram stain can be do. And for the fungus, gram, acridine orange, calcifer white stain can be done. And we have a media called blood agar, Sabardez agar, red hand infusion agar is seen. In the microbacterium, the choice is Lewinson-Jensen agar. In our context, for the cornea ulcer, what we are following is we have different stains of gram, Giemsa, QH stains, and in the for the media, culture media, we have blood agar, chocolate agar, we have McConkey agar. So these are we are following in our context. So this is again for the bacterial conjunctivitis. This is again divided into hyperacute, acute, subacute, and slow. So hyperacute is less than 24 hours. It's a very severe form. So the organisms which are very common for this hyperacute condition is Neisseria gonorrhoeae and Neisseria meningitidis. So onset is from 1 day to 13 days. And in acute or subacute, it's a moderate to severe form. We can found Haemophilus influenzae, Haemophilus streptoneumoniae, streptoviridins, aureus can be seen. But in slow onset, we have Staph aureus, Bajracharya, Enterobacter C, Pseudomonas, chlamydia can be found. So this is again a picture of bacterial conjunctivitis, where you can see a marked congestion in the conjunctiva, and also sometimes you can get very much membrane over the tarsal conjunctiva. So this is the hyperacute condition, as we said, is gonococcal conjunctivitis. Here we can say that it's a marked congestion, very profuse, rapid onset discharge. In the OPD, we say that we ask the patient and our helpers to clean this discharge in 1 or 2 minutes. Again, the discharge is so much; it's very severe, purulent form, and sometimes it's some foul smelling also. So this is this is a very acute conditions. Here, this is a gonococcal conjunctivitis for the neonates. It's a very severe form. In 1 or 2 days, it's landed up in the marked thinning of the involved area. So gonococcal conjunctivitis is caused by Neisseria gonorrhoeae, which is gram-negative diplococci. It's a sexually transmitted disease. The mode of transmission include from genitalia to the hands, then to the eyes, the infected mother to the neonate during delivery. It grows well on chocolate agar and Thermartin media. So treatment is systemic antibiotics. Many a times we have to start intramuscular injection of ceftriaxone 1 gram. If only the conjunctivitis, there is no much corneal involvement, but sometimes if there's corneal thinning, if we see there's involvement of the cornea also, sometimes we have to admit the patient and intravenous injection ceftriaxone 1 gram every 2 hours for consecutive 3 days can be should be started. So in gonococcal conjunctivitis, what I request my residents to take the proper history, give some time to those patients, proper history, including sexual history and other history also, which is very significant. And if we think of gonococcal conjunctivitis, I think we have to rule out the other sexually transmitted disease. So send for the other blood investigations also. And if there is patients are susceptible, then what I have seen that injection intramuscular ceftriaxone has improved a lot in our cases. So we do not have to hesitate on starting the ceftriaxone injections. So another topic is trachoma, which is caused by chlamydial conjunctivitis. So trachoma is according to the WHO, we have 5 key signs on the trachoma: follicular conjunctival inflammation, diffuse papillary conjunctival hypertrophy, tarsal conjunctival scarring, aberrant glasses, corneal opacification. Here we can see that there is a subconjunctival fibrosis. There's a line of subconjunctival fibrosis, which causes very dry, and then it can cause very foreign body sensation and corneal defects on the cornea also. Here we can see that the Herbert splits over the limbus area, and here we can see the pannus in the superior area of the limbus. So as I can say that in the trachoma in 2018, luckily our country has eradicated the trachoma in 2018. So in the management, WHO in conjunction with the International Trachoma Initiative has implemented the SAFE strategy. In the SAFE strategy, S for surgery, which is of trichiasis or entropion surgery, A for antibiotics, and F for facial cleanliness, and also environmental control for the prevention and the treatment of trachoma. So in antibiotics, we can start azithromycin, tetracycline, doxycycline, but I would like to focus on surgery, and antibiotics is in our hand. But the country, our government should also focus on the cleanliness, sanitation, and the environmental control of the trachoma to eradicate the trachoma. So for the bacterial keratitis, the common organism for this is Proteus species, Enterobacter species, Pseudomonas aerugina. So it is very common in the soft contact lens wear, Staph aureus, Staphyloepidermidis, Streptopneumoniae. The research that we do in our Telangana, in our country, here we can see that Streptopneumoniae is the most common organism for the cornea also. So regarding the bacterial keratitis, so what are the risk factors? Trauma, contaminated ocular medications, impaired local and systemic defense mechanism, disruption of the corneal surface, dry eye, any lid deformities, entropion, ectropion, NLD obstructions. These all are the risk factor for the bacterial keratitis. So in the bacterial keratitis, initially it can present with very much small epithelial defect with underlying superficial infiltrate. In this picture, we can see that it has got a deep stromal infiltrates with large epithelial defect. And this is suppurative ulcerative keratitis caused by Pseudomonas aeruginosa. Here we can see that stromal infiltrates with a little bit of some so suppurative also. And here we can see that the hypopene also. So this is again, there's also again a bacterial keratitis with stromal infiltrates and a lot of hypopene. Pseudomonas aeruginosa typically causes the stromal necrosis and mucopurulent exudate. It has got endothelial inflammatory plaque, marked AC reaction, hyperpain. It is more common in the contact lens related biofilm. So this is a condition of infectious crystalline keratopathy. So here we can see that there's a branching snowflake-like aggregates found in the grafted cornea. So management of the cornea also. So goal of the therapy is the prevention of the sight and the corneal integrity. So initial therapy, meaning to empiric broad spectrum antibiotics, which is of topical fluoroquinolone monotherapy. We can use the antibiotics and then sometimes we have to use for the fortified forms also. And the role of corticosteroid therapy is also there. And for the surgical treatment, less than 2 millimeter of perforation and desmatocin tissue adhesive can be used. And if there is facility for the non-healing also, sometimes you use the conjunctival graft, pedicle graft, Gunderson flap also. If there is amniotic membrane graft is available, if the infection has resolved completely, we can use the amniotic graft. And ultimately, lamellar keratoplasty, penetrating keratoplasty with peripheral iridectomy is done. In our setup, as we are in the referral center, most of the cases are very deep and then deep stromal, and it has already infected in the anterior chamber also. So we have to directly go into the therapeutic penetrating keratoplasty. So in bacterial care, in the initial therapy, we have got fortified forms. In the fortified forms, in our protocol, we are using cefazolin or vancomycin for the gram positive, and tobramycin and amikacin and gentamicin for the gram negative. And nowadays, we are seeing that cefazolin and gentamicin are resistant to the most of the patients. So we are starting vancomycin and amikacin for the broad spectrum fortified forms. So what are the indicators that we know that the corneal ulcer is doing good? It's better, so we can still wait for the patient. So these are the several parameters which monitor the improvement. So reepithelialization, blunting of the perimeter of the stromal infiltrate, decreased density of the stromal infiltrate, cessation of the corneal thinning, reduction in stromal edema, and endothelial inflammatory plaque, and reduction in the anterior chamber inflammation. So these are the parameters that the residents should follow for the follow-ups. These are very important for follow-ups. So you are following the patients very frequently in 2 or 3 days. So what things you have to be look on. So you have to keep in mind in these parameters and work up for the follow-ups. So there's a typical microbacterial infection also. So these are the stromal infiltrates, corneal haze in the atypical microbacterial infection. This is the patient after LASIK surgery. So here also there's a typical microbacterial infections. So one of the another important topic is fungal keratitis, which is very much prevalent in our country because our country is mainly on the agriculture basis. So there's a lot of trauma with the while doing field works. So what are the risk factors? Trauma with the plant or the vegetative material, contact lens wear, corticosteroid use, chronic corneal erosion, ulceration, chronic keratitis with herpes simplex, herpes zoster, or VKC, systemic immunocompression, with candida infection. So past corneal surgery with penetrating keratoplasty or endothelial keratoplasty. These are the risk factors for the fungal keratitis. So another keratitis which is very important is acanthamoeba keratitis. This is common in contact lens user in the developed countries, but in our scenario it's quite different. We have the patients with acanthamoeba keratitis with, where some, if the patient is contaminated with the muddy water or sometimes in the swimming pool also, this can be this type of patient present with acanthamoeba keratitis. In acanthamoeba keratitis, it's a severe ocular pain. It's symptoms are more than the signs. When you see the cornea, the infection is quite less, but the patient is intolerable pain. So in that case also, we have to think of in the back of the mind, the patient can be suffered from acanthamoeba. So because acanthamoeba keratitis is difficult to diagnose, so this is very lately diagnosed. So patient complains of photophobia, protracted, it's a progressive course, partial or complete central ring infiltrate can be seen. And because this is very much painful, because this is involved in the perineuritis, radial keratoneuritis. So this is involvement in the nerve system also. So this is very much painful. So this is a picture of the of our patient of Tilganga. So this is a laboratory pictures. Here we can see the mini cyst of the acanthamoeba cyst in this picture. So these are the corneal stromal inflammation associated with systemic infection. So this is the very punctate epithelial erosions in macrosporidiosis, and this is the laparoscopy. This is the macroscopic view of the macrosporidia. So this is a loiasis. This is caused by a loa. Here we can see, we have seen one of the patients, maybe I think 2 years back, Dr. Leena has also seen this case. So this is not so common, but yeah, this is very interesting case. We have seen it, sometimes we have seen this type of cases also. So this is a bacterial scleritis, where this happens after the pterygium surgery. Actually, I think this is a case of necrosis of the sclera. This type of necrosis happens when there is a pterygium surgery with mitomycin C therapy. So we have to also think of these conditions also. So I think that these two are the chapters, and now I'll go to the chapter 10, which is systemic disorders with corneal manifestation. So these are quite vast, so I'll just highlight on the very important very important and common findings. So this is a systemic mucopolysaccharidosis, where you can see a very hazy cornea. And there is also sphingolipidosis in Fabry's disease, where we can see a wall-like pattern of the cornea, cornea verticillata. So this is again amino acid metabolism, different findings in the cornea. This is cystinosis, where we can see a very crystal-like deposits over here. So this is again some shiny type of things in the tyrosinemia. This is again a discoloration of the sclera in ochronosis. There's a deposition over here. So Wilson's disease, this is Wilson's disease is quite common in our context. Many of the physician doctors, they send for the Wilson's disease to rule out the Wilson's disease. So we can see a band of yellowish brownish pigmentation over the base of the cornea. So in Wilson's disease, they have to rule out from the hepatic cirrhosis. Some of the liver disease patients, they send for the Wilson's disease. For this case, we have to see at the cornea very carefully, and sometimes we have to dilate, and sometimes we have to send also for the gonioscopy and see at the trabecular meshwork also, because we can see brownish pigmentations on the trabecular meshwork also. So this is again a Marfan syndrome. Here we can see that the subluxation of the there is a subluxation of the lens, which is quite common in the Marfan syndrome. This type of patients are very tall, long hands. They came in our OPD. So these things. Subluxation should be noted, and for the surgery we have to always think of in the mind of the complication that will create from the Marfan syndrome. So this is osteogenesis imperfecta. Here we can see that there is a blue sclera over the so there's a blue sclera in the cases. So this is again a golden hair golden syndrome. You know that this is a dermoid, where we can see the limbal dermoid and pre-auricular tag. Golden hair syndrome is also common, and you know that dermoid is usually present since birth, but when the patient grows, sometimes this is becoming increasing in size, and sometimes it can also discomfort, and mainly patient come due to the cosmetic reasons. So we have to excise the dermoid. So what we are doing is we are doing corneal patch graft along with the dormant excision. And also we can send for the histopathology to confirm the diagnosis. So another important topic is a nutritional disorder where there is vitamin A deficiency, which is very common in our country. I think this is also common in your part of the world also. So regarding to the WHO classification, conjunctival xerosis without beta spot is so this is 3 classification. So without is X1A, with beta spot is a very glistening things, whitish glistening thing. It's a beta spot. So once it appeared, it doesn't go actually. So the second stage is corneal xerosis. Third is corneal ulceration with keratomalacia. Less than 1/3 is X3A, and more than 1/3 is X3B. So what is the management of vitamin A? So our WHO supplementation, WHO vitamin A supplementation is, I think it's all over the world. So till 6 months, we are supplementing 50,000 international units. From 6 to 12 months is 1 lakh international units. And more than 12 months, it's 2 lakh international units. This is in our country, our government is freely supplying this vitamin A supplementation. And sometimes vitamin A deficiency can be collaborated with protein energy malnutrition also. So we also have to think of, and we have to send our patient to the pediatrician also for the better management. So what are the causes of the prominent corneal nerves? So it is involved in the systemic and ocular conditions. In systemic disease, multiple endocrinal neoplasia, type 2B, Refsum syndrome, Hansen's disease, leprosy, neurofibromatosis. In ocular conditions, keratoconus, ichthyosis, fixed in endothelial dystrophy, congenital glaucoma are the different causes of prominent corneal nerves. I'd like to end my topics. Thank you so much. Thank you for this great opportunity.
Dr. Rita, it reminds me, and Dr. Leena, of a case, a corneal ulcer case that you both brought to my attention while I was in Nepal just a few weeks ago. Dr. Leena, Dr. Rita, would you just give a quick history and blurb about that patient and how you got to the diagnosis and what's happening with that patient, just for everyone to learn from?
Yeah, that case is a young boy around 20 years old, and he came with intense photophobia. He is not opening his eyes at all, and we could not examine him because he was closing the eyes very tightly. And we have to take the patient into operation theater and have to examine under anesthesia. We plan to examine in the anesthesia and proceed. And we thought there may be some perforation, because at a glance we saw very shallow anterior chamber in both eyes. The anterior chamber was shallow, and that was seen at a glance, and we are not sure. So we thought we may need to the patient may have to undergo intervention. So we made ready corneal graft, and then we plan for examine under anesthesia. And during anesthesia, what we saw was there was intense keratitis, interstitial keratitis in both eyes, with perforation of the cornea superiorly in both eyes. And in the worst eye, we did corneal transplantation, and Professor Jeff was also with me, and it was quite helpful that he was with me, and it helped in decision making. So it helped in decision how to proceed, you know. And then we did corneal graft in one eye, and then we also discussed with Dr. Rita. I discussed the case, and Dr. Rita advised to give vitamin A as well, and he received vitamin A. And our next differential diagnosis was bilateral viral keratitis, and he also received asagrobate tablet. And because the inflammation was very severe with corneal vascularization 360 degree, we even gave oral asagrobate and oral steroid as well, and topical steroid frequently, and but patient didn't follow up at all because he's staying in orphanage, and he used to come with one relative, and I was quite worried what might have happened because he underwent such a big surgery, and but he came after around 2 weeks. 2 weeks later, he was opening eyes. Surprisingly, he was opening eyes, and he was allowing us to examine also, and it was quite satisfactory to see that patient's graph was clear and his inflammation was also decreased, and we tapered the dose of steroids, both topical and oral, and also a asagrobate tablet we tapered.
Can you imagine, guys, bilateral corneal perforation, right? You did both eye PKP or one eye, Dr. Leena?
In worst eye. In
the
worst
worst
eye, we did one, and in the other eye, which was there was perforation, there was iris adhesion, but it was self-sealed. And in the other fellow eye, maybe we will be doing optical keratoplasty later on. It was planned later on because it is already sealed. So,
but hopefully he
case.
follows up.
So,
Hopefully he follows
yeah,
up.
I have taken a clinical photographs also, and Professor Jeff was also asking about this case, and I think I'll be sending the photographs soon to Professor Jeff because he is quite curious to know about that case.
Yes, send it to all of us. We would love to see, because that's such a rare thing to have bilateral corneal perforations. At the same time, Dr. Rita's expertise to come in and say vitamin A deficiency should be solved by giving vitamin A. So see, clinical pearl, clinical case that's so relevant to today's conversation.
It is slightly unusual. It's 20 years of age. Usually they are children, and usually the perforation is inferiorly in vitamin A deficiency, whereas Leena says that it was superiorly. And usually the patients give history of severe illness, diarrheal diseases, measles, these are the main ones, but typhoid or something, because I had a little girl, she was one of the 6 children, a girl, 5 girls and a boy, and she had both eye perforated inferiorly, and the treatment would be, and we did a graft in both the eyes, and the treatment would be no matter what age, but because somebody has got keratomalacia, it is 200,000 international units day 1, day 2, and day 15. So this will be the vitamin A supplementation. The chart Rachana showed is the prophylactic laxis, but this is the treatment of vitamin A deficiency. So we don't get that like corneal blindness used to be the second major cause of blindness in Nepal, but not anymore, because vitamin A deficiency is more or less taken care of, although it is declared by the Ministry of Health, and Ministry of Health got several awards from the WHO and all, but we still see some pockets of vitamin A deficiency, like in the orphanage site, Leena is saying, or in the villages where there are lots of children in that family, and somebody gets really sick, and those children usually get vitamin A deficiency, but not as rampant as before, because vitamin A deficiency was one of the main causes after trachoma to have the corneal cause of blindness in 1980-81 survey.
Amazing. 5 minutes left, 5 minutes left. Okay, I just want to say, before I hand it over to Dr. Audrey Rasta for final clinical pearls based on the most recent chapters, is that we have Dr. Tariku from Hawassa, Ethiopia, who's the winner of today's session. Hearty congratulations to him. A brand new SICS set. And so also, Dr. Audrey Rostov, during this session, has pledged a gift for the final session. As you all know, December 8th is the next session, chapters 13 to 16, so be prepared, okay? But next time, You will not get a prize as a materialistic thing. No, no, no. The prize, remember, for these 18 months is for you to learn and be the best ophthalmologist you can be, so you can cure blindness in your part of the world. Remember that. But in the cumulative book review session on December 22nd, the final gift and the criteria I have not given out yet. Okay, so read. But the best selected resident per the criteria that will be selected by Dr. Rostov will be gifted a brand new PKP penetrating keratoplasty corneal set. One resident. Okay, so read. Handing it over to Dr. Audrey Rostov for final words and clinical pearls.
Thank you so much. And thanks to everybody. What great learnings today. So amazing. So thank you. Thank you, everybody. And Dr. Rita, what an amazing case, bilateral corneal perforation, and good for you for clinical acumen. This is to the residents. This is why we're always learning. You know, I mean, I've learned about that. I didn't know about bilateral corneal perforation with a vitamin A. So you're always learning, and you're always trying to be better. And information changes. I would say that what you learn today, some of it's going to be relevant in a year, 5 year, 10 years, but some of it changes. And so it's a lifelong journey of learning. And I think that that's my major pearl for you, is to always keep learning. And, you know, even if you fall on your face, you are still moving forward.
Yep.
I think that is the main teaching here. Just a couple of just brief points, just based on some of the chat between HSV and HZV, meaning between herpes simplex and zoster keratitis. Simplex, the dendrites have terminal end bulbs, and so you'll see these small little end bulbs. It's blunted when you look at zoster, if you look at shingles. For shingles, you do want to use topical steroids from the beginning. From herpes simplex, if it's just epithelial disease, then it's antiviral. And then once that's resolved, you can add a little steroid then. If it's stromal and epithelial disease, then you want to use both antiviral as well as topical steroid. You need both. So I'd say those are the main learnings. There was also an interesting comment, a couple about epibulbar dermoids. And at least when I see them, you don't need to think about removing them. Sometimes you can shave them off, like if it's a problem, you can just debulk them or shave them off, but you don't have to remove this. And so just to keep that in mind. And then one last thing, which I thought was interesting, they said, how can you tell the difference between an endotheliitis and a Fuchs dystrophy? And the point was made, endotheliitis, you're going to see KP. It will also resolve or get better with a steroid. But look at the other eye, okay? Whenever you see something in one eye, you want to look at both eyes. This is really interesting because actually a friend of mine here in the US, a friend of mine's husband, she said, you know, my husband was just diagnosed with Fuchs dystrophy. He had a bunch of different things going on. I said, oh, really? That's interesting. Let me have a look. And we were actually at a meeting, and I took him to the slit lamp, actually at the meeting, and just had a look at him. And I said, oh, this is interesting. He has a little bit of KP, and I'm looking at the other eye. There is absolutely no Fuchs. And I said, I actually think that he has some kind of uveitis. And well, he had actually a zoster. And he had in fact, a little bit of inflammation, anterior uveitis. So always look at the other eye. And I said, if you look at the other eye, And I told my friend, there is nothing, and she's an ophthalmologist. I said, there's nothing there. So you have to really look at both eyes. She's pediatric. She doesn't do any cornea or anything, but you know, look at both eyes. So always look at both eyes. And I think that is my pearl. So keep learning, keep up the good learnings. So lovely to see my colleagues from Nepal. I cannot wait to see you in person again. I'm hoping in the fall with Dr. Rachana. We talked maybe next fall.
Theme of Thanksgiving for all residents around the world is a time of gratitude, being gratitude to your family, to those around you. Let us also be grateful for this opportunity to be future eye surgeons and present eye surgeons, because it is really a gift. It is a gift to be given this opportunity to be able to take care of others who are in need. It is a responsibility. It is a gift given to us. Let us also be thankful for all the teachers around the world who are supporting us. In your own institution, go back and say thank you to them, who are always there by your side and looking out for you. They may be strict sometimes. They may not be looking like your friends sometimes, but that doesn't mean they don't love you. Okay, they love you. And so it is our duty to say thank you to them also. And for final words, we are grateful to each and every one of you residents for walking this path. It may not be easy all the time. I'm not saying it's gonna be in the future either, but it is a path that brings you great joy. For the work that lies ahead of you is something that is, I call divine.